Okay, we can go ahead and get started. My name is Jackie Roux. I'm the program manager for the Michigan Collaborative for Type 2 Diabetes. We are very lucky to have Dr. Oliver Varvan here today, who's going to talk about metabolic surgery and Type 2 diabetes. Dr. Varvan is a minimally invasive and bariatric surgeon at Henry Ford, and he is the associate director of another collaborative called the Initiative, the Michigan Bariatric Surgery Collaborative. After graduating with a degree in molecular biology and genetics at the University of Pennsylvania, Dr. Varvan completed his medical school and general surgery residency training at Wake Forest University. Afterwards, he completed a fellowship in minimally invasive and bariatric surgery at Brigham and Women's Hospital. Dr. Varvan's been an active member of MBSC since 2011, and his clinical interest includes the outcomes of bariatric surgery, access to care, and quality improvement. Thank you so much for joining us today, Dr. Varvan. We're so excited to have you here.
All right, thank you. Thanks for that introduction and for the invitation to speak today on the role of metabolic surgery in type 2 diabetes. I am going to share my screen here. Okay, can you guys see that okay?
Yep, looks great.
All right, fantastic. I'm going to minimize a couple things here so I can see it as well. All right, so once again, thanks for the introduction and for the opportunity to speak today. I'm really excited about talking about this topic, of course, as a surgeon. And as far as disclosures go, as you heard in the introduction, I am a part of the leadership at the Michigan Bariatric Surgery Collaborative. This collaborative started in 2006, and it captures a little over 95% of all the bariatric surgery or metabolic procedures done in Michigan since that time. So we have data on over 120,000 patients, and the collaborative includes a little over 40 different bariatric surgery programs and about 80 surgeons. So we're really proud to be a part of the collaborative, much like yours, as well as to talk to a group like this on a common theme, which is diabetes. So I thought a good place to start is, who's a good candidate for surgery, right? And what are the indications for surgery? And the fact that in the past year, there's been an update to the guidelines on who qualifies for bariatric surgery. And this comes from the ASMBS, and it's really an update to guidelines that were first brought up in 1991 by the National Institutes for Health. And so these updated guidelines include recommending metabolic surgery for individuals with a body mass index over 35, regardless of the presence of any kind of comorbid conditions. And then including in that is recommending metabolic surgery for individuals with metabolic disease with a BMI of 30 to 35. So we're talking about diabetes, which is included in that category of metabolic disease. And this updated guideline also includes the concept that body mass index is not a perfect sort of metric or marker to establish the severity of metabolic disease in a diverse patient population. So it also includes recommending surgery for Asian populations at a body mass index that starts at 27.5. So these are the sort of updated guidelines, which have just, like I said, had come out in the last year. And I think I thought it would be a good place to start in sharing that with this group. And so we can actually do an audience survey question. I think this was something that the Diabetes Collaborative asked me to include there. I thought it would be a good place to start the conversation about when to refer a patient for metabolic surgery. So what percentage of your patients with these criteria who would qualify for surgery do you actually refer to a program? And I'll let Jackie come up with the poll question as you see there. So if you're on the line, go ahead and submit your answer. We'll give that a few minutes for folks to respond.
Okay, I'm gonna go ahead and share the results so everyone will be able to see them on their screen in just a second.
Okay. All right. So less than 10%. It seems like the majority of the folks who had responded to the survey today had included that, and we have 10 to 25% was the next available answer. Okay. I could tell you anecdotally in our practice, the majority of patients do actually self-refer. They come to our clinic based on family member, a friend, or word of mouth, or quite honestly, what they see on social media. So this is actually quite in line when it comes to our experience that we see in clinic, which also speaks to the fact that there are many more patients out there that that can stand to benefit from a surgical program. Well, I wanted to go through some of the evidence that have been provided that really supports these updated guidelines. And as you can see here, the type of evidence that I'll show is actually supported by summarized well by the joint statement from the International Diabetes Organizations. And they've summarized a whole host of studies that, as you see on the right here, really show that surgery favors and is favorable when it comes to patients with diabetes, indicating that there is a significant drop in patients' hemoglobin A1C with surgery. And most folks probably know that already, but I think what is really interested and highlighted within this study is that it's not just amongst patients with really elevated BMIs, but it also includes patients with BMIs of less than 35. Now, the concept of the bariatric surgery improving or not only improving, but potentially resolving diabetes is not new either. This is sort of one of the landmark studies by Walter Porres. This is over 25 years ago when he published this data. And what still is fascinating to me is that not only does bariatric surgery, or in this instance, they use gastric bypass, really resolve or improve glucose homeostasis, but it does so before maximal weight loss has occurred. And a lot of times what we've seen in our practices is that within that first month, most of the patients have been able to improve their glucose homeostasis and actually come off a lot of their medications. And so this has been well known for quite some time, which is, I still think, a very fascinating fact about the impact of surgery on diabetes. Now, some of the newer data actually looks at the beneficial impact in a little bit of a different way. So they're looking at mortality benefit of surgery on patients with diabetes. And so this, in this study, which is a lot nearer than the one that I just showed you from Dr. Porres, really shows you a significant improvement in mortality benefit for patients who have undergone bariatric surgery. And this is data looking at patients over 30 years. So, and just going into the findings of this study even more, this is really fascinating information that the median life expectancy was 9.3 years longer with for patients with diabetes who have had surgery than the non-surgical group, and the life expectancy was 5.1 years longer for patients without diabetes. So you can really see that the benefit or the impact is greatly enhanced amongst patients with diabetes. And that sort of makes sense when you look at how diabetes can impact cardiovascular outcomes, right? So a lot of these metrics, whether it's heart failure, coronary artery disease, cerebrovascular disease, nephropathy, atrial fibrillation, there is certainly a lower incidence and rate of patients developing this who have undergone metabolic surgery, again, because of that impact on diabetes. And that mortality benefit is actually extending beyond just diabetes, but other metabolic markers such as non-alcoholic steatohepatitis, which has been recently renamed to metabolic-associated steatohepatitis. So again, very similar looking graphs when you look at the incidence of major adverse liver outcomes amongst patients with and without bariatric surgery, showing or demonstrating again that it has a pretty significant impact on metabolic disease. And just to add to another sort of newer way of thinking about the impact of surgery, it's actually improving mortality benefit with patients who have increased cancer risk as well. Now, what about the prevention of diabetes? I think that's another really interesting way of looking at how surgery can be effective. And the Swedish obesity study had demonstrated this really nicely in outcomes, or a 15-year sort of following of patients. And again, showing that there's a markedly reduced incidence of diabetes amongst patients who have had bariatric surgery when compared to matched subjects. And one really interesting thing that I wanted to add to this paper that looked at the incidence of diabetes, looking at both the surgical cohort here in orange and then the non-surgical cohort here in blue, is that it really doesn't relate as much to body mass index as it does on the severity of diabetes, indicating that when people present with higher levels of baseline blood glucose, they're at much higher risk of developing diabetes long term. So it's less so about the presenting body mass index or weight, and more so about underlying metabolic conditions. Now, I show a lot of this data about the mortality benefit, but there is a ceiling to how surgery can be impactful. And one of the ways that this has been demonstrated as the body mass index goes up among patients with diabetes, the mortality benefit goes down with surgery. So like I was showing before, there is around a 5 to 10 year of extra life benefit when people have undergone bariatric surgery with who have diabetes. But as that body mass index goes from 35 to 40, 45 to 50, and above 55 and into the 60 range, you can see that that change in life expectancy, that mortality benefit starts to go down. And it sort of levels out at a body mass index in the mid to upper 60s. Another way we can show that there is a limit to the impact of bariatric surgery is also looking at, how likely patients are able to achieve a body mass index of less than 30. Certainly when patients develop more metabolic syndrome, more severe metabolic syndrome, it tends to happen at body mass indexes that are a lot higher. But when patients present for surgery at a body mass index of 50 or above, the likelihood of them getting to a body mass index of less than 30 is only 8.5%. And that sort of makes sense when you look at how bariatric surgery can impact patients' body mass index. It's generally somewhere between 8 to 15 drop in their body mass index. So again, when patients present at much elevated body mass index, the impact of surgery can be minimized as well. Another way to look at severity and chronicity of disease and how that impacts surgical outcomes is looking at resolution of diabetes among patients with different levels of diabetes severity, as well as the amount of time they've been diabetic. So in this really well put study by Dr. Schauer, he looked at patients with impaired fasting glucose. And among those who had impaired fasting glucose, you can see that that resolved 100% of the time with gastric bypass. Patients who were diet controlled, you can see here 97% of those folks had improvement in their glucose and their A1Cs. If you look at oral, when patients are on oral incidents or oral agents, the resolution of their disease was about 87%. And patients who were on insulin at the time of bariatric surgery, the resolution of disease was 62%. These are still really good numbers, but you can see that initial drop in the benefit of surgery starts really takes a hit when patients go from oral agents to insulin. Again, another marker of disease severity and impacting, or the impact of bariatric surgery seems to be much better at lower disease severity. Once that disease severity worsens, then the impact is less. And that's pretty common with a lot of different conditions that we see. Duration of disease matters as well. When patients have diabetes for less than 5 years, there's significant impact of bariatric surgery on those patients, with 95% demonstrating resolution. Once you get above 5 years, when you get into the 6 to 10 years or greater than 10 years, you can see that resolution, or the likelihood of resolution, goes down and down. It's fascinating about those data. And when you look at our data here in Michigan, discontinuation of medication and oral medication and insulin, those numbers actually mimicked very closely to that previous study there. It shows you some of the consistency of how well these procedures work for diabetes. But once again, once you go from oral medications to insulin, the likelihood of discontinuing those medications or having an impact on disease state goes down. And so this brings up the concept of how obesity and metabolic disease lives on a spectrum, right? So when patients have lower severity and chronicity, there's a lot higher likelihood of improving their disease as opposed to when patients present with higher severity and higher chronicity. And so I think this pulls back into the concept of those guidelines or those updated guidelines, in that they are trying to advocate for patients to present for surgery at lower disease severity and chronicity. Because there's much better weight loss, much better comorbidity reduction, much better mortality benefit, and certainly less complications when patients are younger and have less disease severity. And so some of the other ways to think about who's a good candidate or when should people start to think about referral to a surgery program is when you start to have that conversation with the patients of, well, oral medications can only work so much. We may have to transition into insulin. Or maybe they've been diabetic for a period of time and they haven't seen much improvement in their diabetes or A1C during that time. So like I showed you, when diabetes has been present for greater than 5 years, again, the impact of surgery is less. When we looked at data at prevention of diabetes, I think people who have a strong family history and are not diabetic yet, that could be another area where surgery can be very impactful in that patient population to help reduce the likelihood of diabetes, or at least the onset of diabetes, a lot later. The idea of prevention. And I put up there a body mass index of 50 because we do have pretty strong data that when patients are body mass index above 50, the likelihood of them getting to a normal sort of weight or body mass index is really, really reduced. And certainly people present with a body mass index in their 30s before they get up into their 50s. So if you see that quick progression from 30, 35, 40 to 45 in a very short period of time, that might be another ideal patient to at least be evaluated by a bariatric surgery program. Now, a lot of people ask me about whether there's maxes, like if there is limitations to who we can do surgery on as far as guidelines, who would be a poor candidate. I would say right now, that is a question that we answer as part of the evaluation when patients are seen in clinic. As far as age, there are certain programs that are more community-based programs and a lower acuity of care program. And so they may refer higher risk patients to tertiary programs. So patients who are in the 65 and above range may benefit more from a tertiary care center when it comes to metabolic surgery, understanding that they have all the resources to manage that patient afterwards. And same thing goes with BMI. Quite honestly, there is no max limit of BMI that can be referred to surgery. I already showed you that body mass index over 50, they start to have less of an effect of the surgery, and certainly 60, 70, 80, those are much higher risk patients, but they still all warrant an evaluation by a program. At the very least, we can see patients and help optimize them and have some preoperative weight loss within our own program before heading off to surgery. And great example there is two of the patients I'd seen last week, both had a body mass index of 70. And so in those types of patients, we'll optimize them with our preoperative weight management program, as well as our exercise program. And we will follow up with those types of patients to try to lower their body mass index to a range that would make it safer for surgery. And I think people have different ranges of what that should be. But as far as you're concerned, when you see a patient in clinic, the higher limit of the body mass index shouldn't be something that you should think about too much. It'll be up to us to make that evaluation and to optimize the patient for surgery. Is there a question? No, I don't see that question. Okay, all right. So that was probably a lot to digest, a lot to think about as a first pass when you're looking at, what is the current evidence. It's also a lot of information to try to convey to a patient in your own clinic. And what I wanted to do for the second half of this presentation is at least give you, highlight for you the benefits of a referral, because we provide a lot of that education and of the evaluation within our program ourselves. So we can take the burden of answering all the questions from, am I a good candidate, to insurance, to how do I optimize and what's the diet? All of that is built into any kind of referral for metabolic surgery to any program. And that's can be achieved because metabolic surgery teams are comprehensive. There is intake specialists, program coordinators, surgeons, dietitians, psychologists, nurses, APPs. In our program, we also include exercise physiologists, weight management team, and obesity medicine, who actually prescribe as the newer GLP-1s as far as weight loss goes. So we work within a very comprehensive team in order to provide, again, a lot of the education up front for the patients, as well as the evaluation that identifies who are ideal candidates and also optimizes them for surgery for best outcomes. So I think any kind of referral will provide a lot of that education up front for them. And there is a lot there to do. So like I said, for metabolic surgery, the evaluation often starts off with education. So a lot of programs have a video online, or they provide a seminar. So a lot of that information that is conveyed to the patient and answering a lot of those questions does start off with that kind of seminar or video education. Now, after that, there's 3 specific evaluations that every patient goes through if they're going to proceed with surgery. That's a medical evaluation with a surgeon or an APP or a medical person from the team. There's a dietary evaluation from our dietitians, and there's also a psychological evaluation. So all those 3 evaluations are done on every single patient who gets a referral. And they can be very revealing and certainly very comprehensive. In a lot of programs too, that each one of those evaluations, so the medical evaluation, dietary evaluation, psychological evaluation, each one of those are about an hour long. So there's a lot of opportunity there to answer questions and establish rapport with patient and get a sense of if they're a good candidate, but also if they're motivated, willing, and want to proceed with surgery. Now, metabolic surgery evaluation can also include an exercise class. Before operating on the stomach, we certainly offer endoscopy on every patient. So there's a lot of screening things that are done on every single evaluation for every single patient who is referred. We certainly do a fair number of labs looking at comprehensive metabolic panel, CBC. So we're looking for nutritional deficiencies, liver dysfunction, diabetes, and we also screen, of course, for sleep apnea. And we require all patients to undergo smoking cessation and be urine nicotine negative before surgery. So again, a lot packed into both a referral and evaluation and the process towards surgery. So as you can see on the other side of the screen, the patients screen positive for sleep apnea. They get a sleep study. Different patients who have different surgical and medical histories may also warrant imaging, and as well, patients with more comorbidities will have clearances from cardiology or pulmonology, nephrology, hepatology, hematology, the list goes on. But this is the part of referral. It's a very comprehensive way of evaluating a patient and getting them ready for surgery. I think another really important thing to emphasize with every referral is that programs can calculate individualized risks and benefits for every single patient and personalize what the outcomes can be for them. And we can do that in Michigan because we have a really neat calculator. So the data on 120,000 patients who have undergone surgeries since 2006, we can use that data and create predictive models and tell patients what is their likelihood of comorbidity reduction, what kind of weight loss they may experience at 1 year after surgery when most patients maximize their weight loss, and then what their risks are too. And this incorporates about 25 different patient characteristics into the model. And so just to give you an example what that looks like, This is a patient, we're going to compare gastric bypass to sleeve gastrectomy, so you can compare the different outcomes from different procedures as well. So this is a female, 35 years old, body mass index of 37. This patient has hyperlipidemia, non-insulin dependent diabetes, and sleep apnea. And if you look at the predicted weight loss using this calculator, at 1 year after gastric bypass, on average, they've lost about 75 pounds. And after sleeve gastrectomy, they've lost about 62 pounds. So again, we can use this information, relay it back to the patient, and give them an understanding of the differences between the different procedures. As far as comorbidity resolution, based on this calculator, it's measured on likelihood of discontinuation of medication. So after gastric bypass, on average, this patient population experienced 88% elimination of their oral agents for diabetes after gastric bypass, and 85% after sleeve gastrectomy. It's actually fairly comparative between the two procedures based on this patient's characteristics. If you look at hypercholesterolemia, 85% versus 75%, sleep apnea, 83% versus 74%. And on the flip side of that, we also offer every patient, of course, who has our evaluation within a program, what their risks are with surgery. I think a lot of patients may consider surgery dangerous and can be very risk adverse. And in some cases, it is a more complex operation, but at least we're able to personalize or individualize their outcomes based on this calculator. And we can tell patients, look, your risk of severe complications like needing a blood transfusion or another operation, or having a leak or having an extended length of stay is about 2% for gastric bypass and about 1% for sleeve gastrectomy. So you can see this offers a lot of information for the patient, and it's part of any kind of referral to a surgical program. So you can see another example, this will show you how variable the outcomes can be with surgery. And we're going to compare gastric bypass with sleeve gastrectomy. In this case, we have a 55-year-old male with a BMI of 62. So same sort of comorbidities, hyperlipidemia, non-insulin dependent diabetes, sleep apnea. And if you look at this person's weight loss outcomes, it's predicted at about 118-pound weight loss at 1 year of gastric bypass and 97-pound weight loss with sleeve gastrectomy. If you look at comorbidity resolution or discontinuation of medications at 1 year, 75% for diabetes versus 71% with sleeve gastrectomy, so elimination of oral agents for diabetes. When you look at cholesterol, 68% versus 52%, sleep apnea, 41% versus 30%. Again, very data-rich and offers a lot of opportunity to discuss with patients about what their goals and priorities are with any kind of intervention. And just like with the other patient, you can compare complications and risk of the surgery, comparing again both gastric bypass with sleeve gastrectomy or the various procedures that we can do. So these outcome calculators, I think, are fantastic. Personalized outcomes allows you to share goals, expectations, and really comes down to true shared decision-making with the patient about whether surgery is the right thing to do, whether it's the right thing to do right now, and what potential risks there are with any kind of procedure. Now, one really neat thing is that calculator has actually been designed in a patient-facing sort of app. So patients can actually plug in the same sort of numbers and get the same data that we use in our clinic. And they can do this on their own time. And at the same time, actually learn about the different procedures that are encompassed with metabolic surgery. So gastric bypass, sleeve gastrectomy. And I think this is, again, another really great tool for patients that they can use on their own time and help them explore what are the different options that they have for obesity and metabolic disease. And I think this is another good stopping point to ask the folks on the call or on Zoom right now on whether a one-pager that allows for a starting point, a conversation point, a way for patients to start to explore surgery as an option, whether this is something useful and whether this is something that can be used in a clinic. So we'll throw that out there as an audience survey question, and Jackie pull that up, and we'll give that a few minutes for folks on the line to answer that.
Right, it's looking like we should collaborate on a handout, Dr. Barvin.
Okay, all right. Okay, yeah, fantastic. Well, I'm glad to hear that. And close that out. So yeah, 96% of folks said that that would be a useful thing in clinic. And it could be something that you personally can give to a patient and say, hey, if this is something you've ever thought about, here's a little bit, here's a starting point, something to consider when it comes to thinking about it in the future. Not something that we have to discuss today, but something that you can think about on your own time and explore on your own time. I think that could be quite helpful. So looking forward to the discussion afterwards too about what are the best components of what to put on a one-pager for patients, particularly since you know your patients and your clinic quite well. I think other things that can help give you sort of a sense of what is the impact of surgery, what are the basic sort of components of surgery, what are the types of procedures we do, what kind of outcomes are there. I think those can sometimes be distilled kind of nicely on a one-pager as well. So one example of that here is just showing you the different procedures or the two most common procedures that are done, the gastric bypass and the sleeve gastrectomy. So giving you a picture of how different they look, but also giving you a sense of what are the outcomes when it comes to weight loss and complications. And there's different ways to present this data. You can do it as a range of weight loss in pounds. You can do it also BMI reduction and things like that. So looking to the group for guidance as to what's a good way to construct this and put this on paper. As far as post-operative care from surgery, I think it's important for as far as general information goes. I mean, it's pretty well tolerated nowadays. I think the most programs will quote that this is about as safe as gallbladder surgery and hip replacements nowadays. Most people stay 1 to 2 days in the hospital after surgery. The surgeries themselves can run anywhere between an hour to 4 hours, depending on previous surgery and complexity of surgery. But most people stay about 1 to 2 days in the hospital. They return to work within 2 to 4 weeks, so the limitations or restrictions are quite minimal. People are they're ambulating on the day of surgery right afterwards. There's no drains, there's no tubes, there's no catheters. People are started on clear liquids right away, and they're monitored fairly, quite carefully throughout the hospital stay. But as you see there, the follow-up is also close and intense in that first year, and we always encourage annual follow-up as well. So whole nutrition education that goes with surgery, that I like to say that goes without saying, but the progression of the diet is actually quite quick in the post-operative sort of setting. Patients go from liquids to softer foods to purees, and then ultimately eating regular solid foods within that first month. And clearly there's vitamin supplements that are necessary with surgery, so very instructive on what those are, and provide patients not only with samples, but with plans and programs so they are reminded to take their vitamins after surgery. And again, this can also all be displayed on a quick, easy one-pager that can be really helpful for patients to realize sort of what is the post-operative care like. What am I up against? How well is this tolerated after surgery? And I wanted to give time for some, let's see, 12:36. I wanted to give some time for some Q&A. Is now a good time? I did have one last thing to kind of fill the time, because I know it's something I haven't spoken about. I think it's something that is fairly common, and that's GLP-1s. And so perhaps I'll take a second if there are some questions that have come up already through the chat, or if there are any other additional questions, we can open up the conversation out if you would like, Jackie.
Perfect. That sounds great. Yep. If anyone has any questions, please feel free to either unmute or go ahead and put them in the chat. As we're waiting for questions to be submitted, Dr. Barvin, do you want to speak to the one I sent you that was pre-submitted about hypoglycemia?
Yeah. So great question. Do patients experience hypoglycemia after bariatric surgery? Is that something you see common, often, and sort of what are the ways to manage that after surgery? So as far as how common it is, I would say that it is not a typical or not fairly common scenario. But in saying that, I would also say that there's different levels of severity of which that can happen. I think part of the dietary instructions and nutritional considerations after bariatric surgery, I think, address a lot of the potential for hypoglycemia after, in particular, gastric bypass, which seems to have a higher likelihood of hypoglycemia after surgery than sleeve gastrectomy. But this is why we encourage small meals, multiple small meals throughout the day. And we also encourage lower glycemic index type of meals and try to limit to 30 grams of carbs per meal or 15 grams of carbs per snack. It's also one of the reasons that we encourage limiting drinking and eating at the same time, but also why we absolutely tell patients not to drink alcohol either, because that can also affect hypoglycemia. As far as the mechanisms for all that, I would have to do a little bit more research to give you all of the insight of that. But I think part of why we don't see it as much in the post-operative care among patients is that because of a lot of the nutritional education that we give to patients and the recommendations, I think address all of that quite well. There are certain really rare and severe scenarios where the amount of insulin released after a meal and the regulation of blood glucose is completely altered. And in that scenario, I've seen only a small handful of times, and actually had done some research on it during fellowship. And it has happened after gastric bypass surgery where patients develop pancreatic nocidioblastosis. Again, quite a rare event where patients have higher than normal baseline levels of insulin production, which leads to a fair amount of hypoglycemia at baseline. And then with every meal, blood sugars that can get into the 30s and 40s, which leads to patients to really getting dizzy and lightheaded, and actually can be quite dangerous, particularly if they're doing activities throughout the day, driving and things like that. So in those scenarios, it's one of the few and rare instances where actually reversing the gastric bypass can help treat and reverse severe hypoglycemia after gastric bypass. But I would say that that is on the order of case report type of scenarios. And I think more often than not, a dietary sort of instructions and recommendations really helps with patients' hypoglycemic events after bariatric surgery. But that was a great question overall. We usually are seeing we're usually focused in on the other end of the spectrum where patients have very high blood sugars at baseline, and we were trying to control those around the time of surgery. We're often very happy seeing how those are very well controlled afterwards. But in some rare instances, they can certainly overshoot and get into the hypoglycemic range. Okay, there's somebody in the chat here. What is the long-term success rate? Yes, excellent question. And one that's extremely, extremely common. So I think to unpack that a little bit is what do we mean by long-term, right? I'm showing you weight loss outcomes at 1 year. The data from, there's Level 1 data, there's New England Journal of Medicine data that has looked at 5-year data, 10-year data, and 15-year data. And I would say the success rate is quite good. I guess the other way to unpack that question is, what do you mean by success? Is it maintenance of weight loss? Is it maintenance of comorbidity reduction? There's a few different ways or a few different metrics. So that makes it a little bit difficult to answer that specifically as far as, percentages and
Bariatric.
I am not signing the forms, I'll tell you.
Oh, I heard somebody on the line there. Okay. But I do want to point out an important concept that has come up fairly recently when it comes to diabetes and microvascular disease. And it's this concept that bariatric surgery provides what is quote unquote a legacy effect. And so there was a really nice study that looked at microvascular disease. So looking at nephropathy, and also eye exams looking at microvascular disease in patients with diabetes. And what they had noticed is that even among patients who had undergone bariatric surgery and had weight regain and recidivism of their diabetes at 5 and 10 years out, their rate of microvascular disease was a lot lower. They had less risk of ongoing microvascular disease than matched patients. So there is something to say about having a time of not being diabetic in whether it's a 5 or 10 year amount of time that promotes improved microvasculature over the course of somebody's lifespan. So the question, the follow-up is, so success rate with the maintenance of weight loss. I would say that about 10 to 15% of patients will experience some regain of their weight. And that is usually seen at about closer to the 5-year mark. And if you want to compare the different procedures, I think that has occurred more often than not with patients after sleeve gastrectomy than gastric bypass. Now, I quote that number, but I'll also say that is extremely tricky concept when it comes to why do patients regain their weight. There's a vast number of reasons why that can happen. Some of it is, yes, dietary changes or a lack of maintenance of the dietary program after the surgery. But there are a lot of other medical reasons too. There are many medications that promote weight gain that patients are prescribed. There are other comorbidities and conditions. There's injuries. There are other procedures that patients have gone through. So it becomes a tricky way to assess or address the impact of surgery long-term when there are a lot of other things that occur during a patient's lifetime that may promote weight gain. Two of the probably the more common reasons that we see anecdotally in clinic is pregnancy and afterwards is not getting to the same weight that they were before pregnancy, even though they've lost a significant amount of weight with bariatric surgery. And the other ones are immunotherapy type of conditions that depend a lot on prednisone. It seems like prednisone does affect people's blood sugars, makes it harder to treat diabetes, and also has an impact on patients with bariatric surgery. So people with lupus and rheumatoid arthritis I've seen who are on long-term or asthma as well, who require a number of treatments throughout the course of a lifetime that includes steroids, can impact their weight maintenance long-term. So I'm just giving you a couple of sort of quick examples of why that's a difficult thing to measure. But I would argue that, in many ways, we're treating a chronic disease over the course of a lifetime. And it's not too different than treating, let's say, cancer. Cancer can come back too. And so I think the impact of a surgery or a procedure can't be limited to just the event of the surgery itself. And I think that's why I think we all agree that it requires sort of a multidisciplinary approach in order to maintain long-term benefits of, lower weight and metabolic disease treatment. But I like that question, and it's something that's constantly on our mind as far as the impact of the benefit of a procedure. I guess another good way to answer the question of success is, again, comparing to the folks who have not undergone a procedure. So I already mentioned the legacy effect as it relates to microvascular disease. There's another fairly good study of looking at sort of how weight, the benefit of weight loss sort of diverges over time. So among patients who have not had surgery, our weight continues to go up. And so I would argue that even if patients regain their weight, if you had a matched control that hadn't undergone surgery, they would be that much heavier if you look at 5 and 10 years later along their lifespan. That's probably something that we commonly see in our clinics, I think, collectively. Other questions? Sorry, that's a difficult one to answer to an empty screen without having a nice sort of back and forth conversation of what long-term and what success means. So hopefully those were good examples, or at least applicable examples to what it means to to measure success and for how long. Okay. All right. Well, I guess I can end up by talking a little bit about GLP-1s, because there's certainly a more common medication that's prescribed, and I think it's a very interesting one as it relates, of course, to diabetes and weight loss. So it's something that we did using data from the Michigan Bariatric Surgery Collaborative. We were curious as to how many of the patients who undergo surgery are using a GLP-1 preoperatively. And as you can see here, that number has increased as you would expect over time. So it's up to 18% last year. And this, I'll remind everybody, that is exclusively just looking at patients with diabetes. That's within our collaborative data set. And one of the things that we noticed is that the weight loss before surgery was highly variable amongst that patient population. So you had some losing about 5 to 10% of their body weight, total body weight, whereas other people had not lost any weight or had gained some weight during that time frame. So in this graph here, I'm showing you total body weight loss over time. So the x-axis is number of days from their initial evaluation to the day of surgery, and then that y-axis is the amount of weight loss. And every one of those is sort of a plot graph of all of those 1,000 people in that from the data registry. So there's quite a lot of variability. And what we've learned is that not only is there an increase of use of GLP-1s before surgery, folks that were on GLP-1s had higher rates of metabolic disease, but also more severe disease. So they're more likely to be insulin-dependent diabetics and have high rates of hypertension and hyperlipidemia when you compare them to diabetic patients who are not on that medication. Looking at sort of means or averages for all of that patient population, the mean pre-op weight loss was 3.6% of the total body weight. But as you can see there was quite a range. So some people got up to about 8% of the total body weight loss, whereas other folks actually didn't lose any weight. They gained about 2.3% of weight. And so what we noticed is that in those patients in the top tercile, that there were patients that tended to be higher BMI, but also lower rates of insulin-dependent diabetes. So they had lower disease severity, and it seems like they had a better response from the medication. There's still plenty to try to understand with GLP-1. Certainly, we need better long-term data to see if using one before surgery can improve or affect weight loss after surgery. So again, this concept of treating metabolic disease in a similar way as cancer, looking at neoadjuvant treatments with adjuvant treatments around the time of surgery. So exciting times for co-collaborating and having a multidisciplinary or comprehensive approach to treating metabolic disease. As far as postoperative or adjuvant care and using GLP-1s, one of the things that we have done with our Michigan Bariatric Surgery Collaborative Data Registry is identify patients who may not get to their weight loss prediction or goal based on that calculator, and identifying when they are dropping off the curve as far as maximizing their weight loss. And we have found that that we can predict that at about the 6-month range. So we're starting a project to utilize some of these medications at that 6-month mark, right after surgery, to see if combination of surgery and GLP-1 this early on can maximize weight loss afterwards. So like I said, these are exciting times for treatment of metabolic disease and diabetes, because we have a true way to use multimodal treatment and having comprehensive treatment. And I think that we'll take a multidisciplinary approach. So really happy to take any additional questions and also hopefully collaborate with people in the future. So I have more time to answer questions. I guess if you're looking for a surgery program close to where you practice, right up here, and the arrow here shows, if you click on this collaborative button from our MBSC website, you can see all the different programs that participate in the MBSC. These are metabolic surgery programs, and you can have easy access to how to contact them. So thought I'd add that there for all of you in case you're looking for a program close to where you practice. And again, really happy to be a to answer questions and be a resource for the group if they have any questions moving forward or like to collaborate on anything. Okay, we have a question here from Erica. Do you find patients require their GLP-1s post-surgery, or do you routinely discontinue these medications after surgery? Would think the side effects may be increased post-surgery and or may not work as well given the mechanism of surgery and where the receptors are. Erica, great question. I don't think there's a good answer for that right now. This is where a lot of the research is really necessary. In general, we do stop GLP-1s before surgery, and whether we start them afterwards or not will be based on whether they have adequate blood sugar control. I think one of the issues that are in our mind after surgery is, will this create a hypoglycemic event that would be dangerous for the patient in the early postoperative period, recognizing that blood sugar control happens quite immediate after the surgery, way before they have maximized their weight loss. So I think it poses a tricky way to manage patients, follow patients in the early postoperative period, and we would be concerned for hypoglycemic events. I think this is another opportunity to collaborate with, particularly with patients that measure their blood sugars or have a blood sugar monitoring device to see the impact of surgery plus a GLP-1 on their blood sugars throughout the day, both at baseline and after meals. So, but again, lots of opportunity to help answer some of these questions that I think we both have, or that we all have. Excellent. Well, wanted to keep that on time, but also include some interesting sort of novel information that, or at least for the future holds. And again, really happy to collaborate and work with folks if they are interested in a one-page sort of conversation starter that patients can walk away from clinic and then on their own time and under no pressure start to evaluate how surgery can fit within their treatment paradigm. And I think that's the best we can do as healthcare providers, is offer different interventions and then offer the best intervention for the right person at the right time. And knowing that this is a chronic disease, different interventions may be more ideal at different time frames. But I think with every sort of evaluation or referral, at least patients get a personalized understanding of where surgery and what surgery means to them. A good example is, again, somebody I saw last week who we originally had seen about a year ago. This is a patient who is on the BMI of 35 range and was sort of sitting on the fence as to whether that was the right treatment for her. And a year later, diagnosed with lupus, multiple rounds of steroids, ankles that were she was in so much pain from ankle and joint pain that she was rendered quite immobile for a period of time, wasn't working out 4 times a week. And so she came back to clinic. It was only a year later, BMI of 38, and much more interested in pursuing surgery. But knowing that she'd been through the evaluation beforehand, she thought about that throughout the course of the year. And I think that's, again, ideal sort of scenario for patients to know what the surgery means to them and where they can maximize their benefit. And then they can come back at a later date when they feel like it's the right time. So just wanted to share that story as another example. Is again, with every referral, they get information, and they don't have to act on that information right away. It doesn't commit them to a surgery right away, but it provides a lot of education and that seed of like, maybe it's right for me, maybe it's not, maybe at a later time.
Thank you so much, Dr. Barbian. We really appreciate you being here and giving this really great presentation. This is really helpful for the collaborative. We will absolutely make sure to follow up with you about a one-pager and what we can do in that space so we can create something like that for the collaborative based on the need identified. But this was really, really helpful.
Wonderful. I'm very glad to do it and love doing it every time. It's one of my favorite things to do. And as far as the slides go, I know there's a lot of information, a lot of past studies and things like that. I'll provide those slides in a PDF so everybody can have them.
Great, thank you so much. And thanks everyone for joining. We really, really appreciate you spending your afternoon with us. And thank you again, Dr. Barban. Everyone have a great rest of your day.
Take care.
Bye.